Hi, everyone. My name is Danielle Jeudy. I am the BCBAD and Clinical Supervisor for our house, and we're going to be talking all about health services. And so I want to start off by introducing who we have here. Um, so look, see, I already messed up. We're going to go over the key support areas. And so the key areas in which the individuals in health services support are residential, day services, as well as admissions and transitions, training and appointments. So all your medical appointments. And so now I'm going to introduce who we have here. First, we have Jackie Van Orden. She is Director of Health Services. We have Pat Vogel, who is a healthcare coordinator, and Nona Saad, who is a dietitian. And so to introduce them, I'm going to start with Jackie. So Jackie has been with our house for 17 years. She holds a BSN from Seton Hall University, go Pirates, an MA in school and social work and guidance from Keene University, and certifications in psychiatric nursing. She has published research on opioid withdrawal and was awarded our house Employee of the Year. Her background includes medical surgical, labor and delivery, and ICU nursing at Clara Mass Medical Center, as well as a charge nurse at Fair Oaks Psychiatric Hospital. Jackie is passionate about helping individuals reach their maximum potential, and in her spare time, she enjoys spending time with her husband, her 3 adult children, and her grandson. So say hi to Jackie. Then we have Pat. So Pat has been with us for 10 years. Pat received her RN from Winfred Baldwin School of Nursing and worked in telemetry care at East Orange General Hospital. After her daughter was born with Down syndrome, she transitioned to working with individuals with special needs. At our house, Pat conducts quarterly home visits, monitors medication and records, trains staff on resident diagnoses, attends medical appointments, as well as serves as a resource for health-related questions. Last but not least, we have Nona. Nona has been with us for 13 years. She holds a degree in clinical nutrition and began her career in hospital settings. As a mother of an adult daughter with developmental delays, she brings both professional expertise and personal understanding to her work. At our house, Nona trains staff on specialized diets, manages group home menus, and supports clients and families in navigating dietary challenges and goals. And so these ladies bring a wealth of information and knowledge. And so we're going to go into some of the main areas and topics in which they receive the most questions about. So we're going to first start with managing weight gain and also weight loss. So Nona's going to share some information and background on this topic.
Hi, I'm Nona. I work for our house in the residential and also with the day programming. Managing weight gain loss is part of what I do, but I will tell you everything that I do first. I do annual diet trainings for every resident in our group homes, as well as day program diet training. We have a lot of residents and clients who have special diets, such as diabetic, calorie controlled. We have a lot of allergies, nut allergies, gluten allergies, some more complicated allergies. We have a lot of residents on special heart healthy diets where we're limiting sodium, fiber, and cholesterol. So first of all, I have to make sure that all the scripts are up to date. Each resident goes for at least an annual physical. Sometimes I'm needed to speak with the physicians if some changes are needed. Sometimes I'm in touch with speech pathologists because we have an aging population and dysphagia is a problem with many of our residents. So the speech pathologists will do a swallow study and they can make recommendations for the physician, and I follow through with what is recommended. We have a lot of clients on special food consistency diets, ranging from chopped into big sizes, chopped into little sizes, ground foods, and pureed foods. Some of the residents need their liquids thickened because of their dysphagia, and so I'm in charge of training the staff so they know how to properly mix the powder that we have that they purchase and to thicken the liquids. I am in contact with the managers and the area directors and the group home managers. I'm in charge of the menus. Each group home has a 4-week rotating menu, and I have been made the original menus. The staff can do some tweaking, and we work together on that. We have different menus. Each resident has their own menu because they are dependent on what diet they are on. But as an overall, I try to make sure that at least for the dinner meal, the staff is only cooking one meal. So we might need modifications, but I try to have the same entree and side dish for every resident to make things less complicated for those who are cooking. Speaking of cooking, we have a variety of staff who range from people who love to cook, do a lot of cooking, to some staff who don't know how to cook at all. So I have menus in the houses, and I have a book of some simple recipes. And I have gone to the houses to cook with the staff and cook with the residents so they can at least be able to make food for their clients. I am in charge. Sometimes I've bought some kitchen supplies for the staff. We've introduced air fryers to have cook healthier versions of foods. A lot of the houses are using air fryers in a lot of their cooking. It's safe for the house, and it offers a lower fat way to cook. I have taken the residents food shopping, as well as sometimes the staff gone to the supermarket. We are trying to get most of our houses to do online shopping. It makes it easier. So they are all registered with ShopRite from home. Some of the houses do like to take their residents out to the food store, but it is an option for everybody. ShopRite offers a 5% discount to all of our homes. So I get their discount cards for all of the homes. Each home has their own. And when they are in need of replacement, I am in charge of that. I have been in the day program and done a lot of cooking classes with the residents. They enjoy it. I've enjoyed it. I try to do healthy recipes. And so it zeroes back to the first question about managing weight loss, weight gain. I've tried to introduce our residents to try new things. Sometimes they'll think they don't like a vegetable. And so, for example, if I've made a pizza and I might put a different kind of vegetable they've never had on it, and they might look at me and say, "Oh, I like it." So, I mean, I know even for my own daughter, they might first say, "I don't like this," but a lot of times, if you get it to try it, or even in a different way, for example, offering the cauliflower with a little dip, they might like it more than if you just tried to put it in a salad. So as far as the weight gain, weight loss, if the doctor has a resident on a specialized diet, the menus are written to say what amount of food they're supposed to be giving them. For example, 4 ounces of a meat, or half a cup of a starch. Each house has a scale, and they should be weighing their food. And some of the houses even have portion plates, and we use that. So sometimes, a lot of times, I've spoken with a family and discussed, for example, we have some different culturally background residents, and some of them are used to their special foods. So sometimes the family may provide those foods that their loved one likes in the house, and we work with that. So in the rare occasion, we do have people who have weight loss. We have supplements. Some of them are on supplemental beverages, and I have some of them are on high protein diets. So everybody's diet is individualized. And I think I answered that question.
Perfect. Thanks, Nona. I know one other thing that you didn't mention was how the staff track. So they do weights for them, correct? To keep track of kind of like the gain and loss of their weight, just so we can kind of stay on top of it.
Yes, everybody, sorry, I forgot that, has a chart, and they're supposed to do weekly weights on the clients, and I monitor that all the time.
Perfect. Thank you. And so the next thing which kind of ties into that is kind of also kind of how you already led into the things that you're already doing as far as having air fryers and teaching them different ways of cooking and trying new foods or cooking foods even if they're not skilled in cooking, because as you said, some of the staff are not, that's not their forte. So is there anything else that we can add, or from Jackie or Pat, from building healthy eating habits? Is there anything else that you want to talk about that specific topic?
Well, I will. We have some clients that live independently and they will go out to the store and buy snacks. And so I will talk to them about healthier snack choices, and especially for those who are in charge of their own food. So I'd say, and then keeping up with the staff. I think that's a big part of what I do, is being in touch with the staff, because they're the ones who are there every day, making the meals, um, serving the meals. And one other thing I just will go back to talking about the staff. It's really important that all of our staff are there to supervise the residents while they're eating. And so that's something that I make sure to let them know, because we need somebody there sitting with them while they're eating. So the staff plays a very big role in the nutrition.
And
Absolutely. No, I
also,
totally agree.
I was going to add also some of the residents, their orders are to stay in an upright position for at
Yes.
least a half hour. Some of them are an hour after they eat because some of the medical issues that they have. So both myself, Pat, and Nona reinforce with the staff that they have to be very vigilant after meals, because you don't, if people have swallowing issues or regurgitation issues, you don't want them laying down. Um, so that's also reiterated to them with this when you're building that healthy eating habits. Because how about when they go, because they're taken out to eat, well, at least once a week for lunch clubs, and they're also, there's parties at
A
the,
lot of parties.
a lot of parties at the houses. So Nona, like at times, if they're going out to a restaurant, we'll have the menu beforehand and help them choose an option before they get there so that there's no um,
Behaviors.
behavior, so to speak.
So,
So that's
and
another way.
I've also provided food choppers for the houses, because sometimes they'll go out and they'll need their food chopped. So I've bought cordless food choppers that they take with them when they go out, when they don't have their larger ones that are in their kitchens.
Yeah, that's super helpful. I think that's important for that community integration, and also knowing that they can, individuals who have those special diets can still enjoy the foods that they like to enjoy, even if it has to be prepared a little bit differently. All right. So one of the next topics that we're going to talk about is increasing exercise and movement. As we know, sedentary behavior is not something that we want our individuals to have a lot of, and so exercise and movement is critical with the individuals we support.
Most of the houses have treadmills, which I've purchased with some monies that came about years ago. And so a lot of them use them. A lot of the residents have memberships to the Ys. And when I do my training, I'm always talking to the staff about recommending, especially when the weather's nice, and we're capturing on the end of that now, to take them outside, to take them for a walk. Some of the houses even have swing sets in the backyard, or like to play ball in the yard. They all have space in their houses. So it's something that I discuss with them all the time. And once again, it's up to the staff to follow through with this.
Yeah, absolutely. I know a lot of the homes also have basketball courts because a lot of the guys like to play basketball, and so that including the schedules for the day programs also include some of those YMCA or gym specific activities to keep them moving.
Yeah.
And they also go swimming
Yeah.
We have a few individuals that, have an interest in horseback riding.
Oh, yes.
So um, we have actually, I think we're now up to two, three individuals that go for horseback riding, and many of our individuals like to bowl. So
Yes.
they are on bowling teams,
And Special
basketball teams,
Olympics.
and Special
Special
Olympics.
Olympics. My daughter's on a Special Olympic bowling team, and we always see the Our House residents there. So a lot of them are pretty active.
Yes.
Yes.
Perfect. So the next topic we're going to talk about is understanding medication. And so this I know is a big topic and a catch-all. So I'll let you guys identify, what specific areas you guys want to talk about with understanding medication.
Okay, so sometimes, like Nona said, I haven't really gone into, and Pat hasn't, what we do in terms of training in the homes. But especially if there is a new medication and people are unfamiliar with it, um, we go in and train, tell them the side effects, what to look for, what it's used for. We also advocate for the residents if it's making them tired or we notice side effects that could be disruptive to their lives. We intervene and call the doctors or have the house managers call the doctor. But we also have, at least I have had, and I'm sure Pat has, at times family members call and want to know what they're on, why, what's it used for. So we go over dosing, when they get it, why they're getting it, what the doctor's understanding is. Or sometimes we advocate for the residents when we feel they're too sleepy or staying up all night, which is a big issue as for anybody. If somebody's up all night, they're not functioning as well in the daytime, or they'll go and try and sleep a day program, or when they come home, they'll want to go to bed and then they're up again. So it's a kind of a vicious cycle that we want to get them out of. So we impress upon the staff that if they see any of these behaviors, they have to report it to Pat, myself, or their managers, so we can, like I said, advocate for the residents and speak to the doctor. And sometimes the doctor might have to adjust the medication. Sometimes they will take them off the medication. Or sometimes when the residents go home, families will report to us that they saw some adverse effects with these medications. So again, we'll deal with that with the doctors or in an appropriate manner. But now there's a lot of medications that are taken intranasally, nasally. So we have to go and train the staff on how to give that medication, both in the day program and in the homes. And then Pat, I think, is going to touch on when we get into a little further training. We train them on insulin, the staff. If anybody in the house has to get like insulin, Wachovia, Ozempic, Trulicity, those are all medications that require injections. So the staff that will be administering that, we train them. When I say train them, we go over what the medication's about. If there's a video, we can show a video. We go through steps. We have them demonstrate it to us. Most of the medications have trainers, like for instance, EpiPen. We have to explain to the staff how to do it in time of emergency and why they're doing it, because that's important. And not everybody feels comfortable in giving an injection. So we kind of go over that and we kind of sift through if we really feel somebody is not understanding what they're doing, either they have to be retrained or get more training, or perhaps they're just not somebody that can do it. A lot of people have issues with giving an injection. Let's see. Pat, you want to add anything?
No, not really. No.
Okay.
All right, perfect. And so you guys did talk a lot about the training. And so I do want to mention also that the staff do go through a very intense training initially just to learn about the process of medication, how they need to sign for medication, if there's any errors in that process, if there was a mistake on medication. So they do an intense training, and then they get additional training from this team as they're going into being more hands-on. So between the training that's required for our house, the training that's required through the state, as well as the things, they are well prepared for understanding the medication. And, there's a lot of follow-up and follow-through on those different areas, which is important. And so the last of the topics is responding to behaviors, which I'll let these lovely ladies talk about, since that I'm usually talking about responding to behaviors, but we want to talk about it from a health services standpoint.
Okay, well, what we find, or what I find, all of us, when we go into a house, it's very important when we do our trainings to make sure the staff understand the behaviors in terms of what the diagnosis is, because not everybody's familiar, let's say, with a bipolar and what bipolar individuals can do when they're in, let's say, a psychotic state, or when they're depressed. So we always we train the staff on the symptoms, what to look for, and if they have a behavior, some alternate ways to deal with it. One of the things that they do get training in as soon as they come in orientation is handle with care if there are behaviors that, if somebody can't be like talked down from what's going on. So the staff is prepared to handle the situation in a responsible, safe manner. We also go over if the staff doesn't understand a behavior, to report it. Like with dementia, for instance, somebody will off the cuff say to me, "Oh yeah, she's getting up in the middle of the night and getting dressed to go to program." Well, that's important to know. If they're confused, if they have what we call sundowning, where they're confused like it says, when the sun goes down, if they have things that they used to be able to do more appropriately, that's changing. That's all stuff that has to be reported to their doctor. And if they're not seeing an appropriate doctor, either at the neuroscience center or a neurologist, first we go through their primary care physician, report any symptoms that might explain their behaviors. And to make sure that there's no medical reason for their behaviors. And then usually it goes on from there to either a neurologist. Like I said, several of our individuals go to the neuroscience center. If it's behaviors that maybe the staff are not familiar with, we call in the behaviorist, AKA Danielle. And she's very proactive in coming in, explaining things to staff and training them on a behavior plan, which then the staff follows. So we really have a lot of backup systems in terms of the staff knowing how to respond to certain behaviors. They'll give suggestions. When we go in, we give suggestions, even if it's a behavior of, trying to grab water or something to that nature, we go in and say, well, how about if you do this, or don't leave the cups on the counter, or, whatever it might be. You want to add anything to that?
Sometimes we have some behaviors that are spurred by food, and sometimes we have to take that out of the equation, or it's easy to respond to behavior and give something that they're not supposed to have. So that is sometimes we have to think of alternate responses to the behaviors.
Yeah, absolutely. You both brought up some good points as far as, from my perspective, ruling out some of those medical causes, because they can display and show themselves in different ways. And so sometimes if someone is in pain and it's related to a medical cause, they may be exhibiting behaviors that are problematic, but that the cause and the root cause are very different. And so we would handle it in a different way. Just as Jackie said, if someone has dementia and they're sundowning, some of those behaviors that may come along during that time have to be approached differently than we would in a traditional way if we're looking at the function because someone wants a cookie that they can't necessarily have. And so, we do have to consider the medical aspect of everything before we can just jump into some of the very scientific behavioral components. So, working directly with health services, as far as Jackie, Nona, and Pat, with the behavior team is important because we can merge them together and really look at the case as a whole versus kind of picking apart the individual behaviors. Is there anything else? I think this, like I said, this is the last topic. Is there any other topics or things that you guys want to discuss or talk about before we close this out that we
Yeah,
haven't talked about yet?
we're going to go over, I think Pat's going to start. I think we're going to just give an overview of
Okay.
everything else we do look at. So
Okay.
you have an idea of the totality that we give all the residents in terms of health and behavior and um, activities. So we'll start with Pat. She's going to go over what we do in the homes, and then I will do the other stuff.
Perfect. So I'll go back to this opening slide.
Okay, so I go into the homes. I try to get there once a month, but sometimes it's once every 2 months. And when I go there, I meet with the managers and we go over the medication administration records, make sure everything is properly there from the pharmacy, make sure it's been given at the time it should have been, and any other things that need to be clarified there. Sometimes I have to call doctors and clarify prescriptions. The prescriptions, of course, have to be up to date and everything has to be clear and on the medication administration record in compliance, and it's on there correctly. Sometimes I do specialty appointments just to make sure that we're getting all the information correctly and to see what each individual might need. We also do trainings every year on every diagnosis that a resident has, and new ones sometimes come up during the year. So we will go in and we will train on that, especially if someone is on blood sugar checks or blood pressure checks or there's injections involved. We have to go in and train and make sure that they're totally comfortable in giving what they're giving and knowing what they're doing. Also, every time they go on a doctor visit, they come home with paperwork like a provider visit record, and we go through those and make sure that nothing is missing in terms of a follow-up appointment, or maybe they need an ultrasound or something, and just make sure everything is covered that's supposed to be. We also make sure that their annuals are done. They have to have annual physical, dental, eye and ear exams. And we just make sure everything's up to date. That's it. I think I'm good. How about you, Jack?
Yeah, well, I think our biggest role is that we just make sure that the staff we usually have the most contact with the either area manager, area director, or the house managers, because we want to make sure, like, we might follow up if I see something, because they do post these provider papers, so we can read them and see if they missed anything, so we can have them follow up. To make sure, or if they don't understand something. I mean, I don't always understand everything a doctor writes, so we might have to go over that and find out what the doctor was intending, and that might entail calling the doctor's office and saying to the nurse, "Could you tell us what he tried to write here?"
Mhm.
Also, when an individual goes into the hospital, our role is to ensure that they are getting advocate for them. Not everybody is always comfortable with handling developmentally disabled individuals. So, they might not be aware that they can't just let them walk off the unit. So we go in and We make contact. Usually it's with obviously the nurse on the floor, but the doctor, but also everybody when they go into the hospital is assigned a nurse case manager and a social worker. So we have found that the first person in line that you should get in touch with is the nurse case supervisor because she will find out what you need to know and she will tell us what medically is going on or if we have concerns. She can relate it to the doctor when she goes into rounds. Um, Obviously, the guardians are involved, but sometimes, if there isn't a guardian involved, then we have to be the advocates for the individual. We also ensure that, when they are ready to either be discharged home or if they have to maybe go to a subacute for either rehabilitation or recuperation, that we are in contact with the social worker to make sure that they're going to a place that's, we feel that we've checked out and we feel is appropriate for them. Because we also have to worry about, we do have individuals that can get agitated. We have individuals that might um, elope. So we have to let them be aware and, so that we advocate to get them a sitter if we have to, if we feel that they can't be left alone. But it's the mainstream of information because nobody would know that. Um, then when they're ready for discharge, either from the hospital or from the subacute, we are involved because we want to make sure, especially if they go to a subacute, as we go to visit them, we want to make sure that their diet is appropriate and it's written appropriately. We have to make sure that all the medications are written so that it's within what the state wants us to have, which a lot of times the hospitals don't always understand some of the rules, but we have to, advocate. We want to make sure that when they are going to be discharged, that it's an appropriate discharge. There has been at times they want to discharge someone, but they can't even get out of bed or walk. And we're like, no, this person was walking before they came in. We need to make sure that they're appropriate for a group home setting. So, we try to get, rehab involved. We go to meetings. Whatever the diagnosis is, we then go home and go back to the group homes and train the staff on any new diagnosis. And we have to ensure that all equipment that the residents may need, be it walkers, um, commodes, uh, Hoyer lifts, that all of that is secured before they're brought home. Um, and like I said, then we train the staff on it so that they're prepared when the person comes home. We also, with doctor's visits and with hospital stays, we send out emails to make sure everybody is aware of what's going on and how the individual is progressing. Um, I think that's it for hospitalizations. And I also just wanted to touch a little bit on which we did for the dietitian Nona going over there. We also train at the day program because if an individual in the home has a certain medical problem, we can't just assume that the day staff know what's going on. So at times, we go over there and train on different medical procedures, on different medication administration. Um, like I said before, when they're all trained on EpiPen. So we're involved in training the staff on EpiPen, and then they get recertified every year with accordance to the state. So we go into the day program, residential, they have in-services, we go and help with that. Let's see. We
I think you made
also,
all good points, Shaki.
I'm sorry?
No, I said I think you made all good points on those things. So those are important, that staff training component for sure.
Yes, and the other thing, just to let you know, we do orientation trainings.
Mhm.
And as Danielle mentioned before, that week or two of training for new individuals, new staff, um, they're trained, and we go over bloodborne pathogens. We go over the elementary reasons for diabetes, make sure people understand how serious it is. We do EpiPen, correct lifting. So we go over a lot of the basics right in that first week that new staff are coming, because we don't want anybody to go into a home feeling insecure that they don't know what they're doing. Because if you've never worked in this field before, it can be a little challenging. So we want to make sure the new staff is prepared for what they might encounter. Um, I don't know. I think, do you have any input?
I think we pretty much covered it. We're really an interdisciplinary team, I guess.
Yeah.
When we all work together. Nobody is in their own cocoon. We all interact and
No, yeah, no,
Yes.
absolutely. You're right about that, Nona, for sure.
Right, and when we're asked to, we do participate in interdisciplinary meetings to discuss maybe better ways to support our individuals, or things we feel would help them. Um, so we're pretty much available for anything we're asked to do.
yes.
7 days a week, it seems.
So perfect. So that kind of takes me to those key takeaways. And so I do want to thank you, Jackie, Pat, Nona, for sharing your expertise. And just hopefully that this conversation, which we wanted it to be more of an informal conversation about health services and all the things that these ladies do. And so that you guys can have some practical strategies, you understand the background, you understand the training, and also have reassurance that we are working together, as Nona said, as a team. And so a few things to remember is that first, you're not alone in navigating this. We are here doing this all together. And we're always here to support you as if you're a stakeholder, as far as a family member or individual or staff member. Secondly, don't hesitate to reach out to questions. We are all available to answer questions, and I'll provide you with Jackie, Pat, and Nona's emails next. But whether that's about weight changes, medication, behaviors, or anything else, just it's better to ask than to just assume assume an answer. Ask a question, and we can provide a solid answer for you. And also that we're stronger when we work together. And so we are all partnered together in doing this as a combined team, so that we can get the best outcome for the individuals that we serve. And so thank you, ladies, so much for that, for all the information, for sharing your input and, like I said, your background and your expertise. These are their emails. And so, again, if you have questions, you can always reach out to them individually and use their emails that are listed here. Is there any other final closing remarks before we end?
We've covered it.
All right. Perfect. Thank you guys again. We appreciate
you.
your time and attention, and have a good one.
Thank you.